Hello and welcome to the lesson on surgical construction of continent urinary diversions. An intestinal urinary diversion is simply a term to describe elimination of urine from the body by way of a surgically constructed intestinal segment. Just like an ostomy, the diversion is generally named from the intestinal segment used to create the diversion. In this lesson, we will review continent diversions, or surgically constructed urinary reservoirs that have a catheterizable channel to pass urine, or the channel has been surgically constructed to allow for passage of urine via the urethra. There are many different reasons or indications for a urinary diversion, including cancerous and non-cancerous pathologies, with the most common reason being bladder cancer. Non-cancerous pathologies would include conditions such as neurogenic bladder, radiation cystitis, interstitial cystitis, and traumatic injury to the bladder. The diversion is used when a bladder must be removed due to the disease process that impairs bladder function, or to actually treat the disease process itself. The continent urinary diversion, or cutaneous catheterizable urinary diversion, involves the creation of an intestinal reservoir with an intestinal channel that connects the reservoir to skin level for the purpose of emptying urine. While different bowel segments can be used for this purpose, use of anatomically convenient intestinal segments would be most often used. The benefit of a continent urinary diversion or reservoir is, of course, that the patient does not have to wear an external pouch. There's control of when urine emptying occurs, there is protection for the upper urinary tract, and the person can better adjust to the body image changes as a result of the surgery. Some individuals state that having a continent urinary reservoir, in particular a neobladder, increases a person's health related to the quality of life as compared to ileal conduit. However, this idea remains controversial. The goals for creation of a continent urinary diversion include preservation of continence, creating a low-pressure reservoir that will protect the upper urinary tract and at the same time preserve kidney function, and also to have a reservoir of adequate capacity for ease of patient management. The most important goal, of course, is to create that low-pressure reservoir in order to protect the upper urinary tract, specifically the kidneys. Immediately after surgery, the capacity is about 120 milliliters, or cc's. At 6 months, that increases to 350 cc's, and at 12 months, the capacity can reach as much as 500 cc's. Like any surgical procedure, there are disadvantages that need to be considered. The surgeon has responsibility to consider and weigh the options for the patient and then discuss the pros and cons so the person can make an informed decision. In the case of a continent diversion, the operative time is much longer, there's the potential for metabolic complications, and it's important for the surgeon to have expertise in the procedure. Metabolic complications can include vitamin B12 deficiency, diarrhea, and electrical imbalances, that is, metabolic acidosis. With regards to the neobladder specifically, some of the initial setbacks can be at issue for the patient, and these would include nocturnal incontinence, which can occur in up to 25% of men and 50 to 70% of women, the need for pelvic muscle exercises to continually strengthen the external urinary sphincter in order to obtain optimal continence during activities, and the potential need for intermittent self-catheterization of these neobladders This can happen in about 30% of women and about 5% of men. For this reason, self-intermittent catheterization is taught to these individuals. Additionally, people need to realize this is not an actual bladder. The neobladder is a substitute for the original bladder, and the individual needs to relearn the signals of fullness and strategies for emptying this new or neobladder. Continent urinary reservoirs can be done as a primary procedure, such as for incontinence, bladder tumor, interstitial cystitis, or neurogenic bladder, or a variety of other reasons. The primary reason is usually bladder cancer. Reasons for converting from an incontinent to a continent procedure includes problems with the ileal conduit, such as persistent urinary tract infection, a poor stoma location, difficulty wearing an appliance, and dermatologic complications such as severe psoriasis or allergic dermatitis. Contraindications for this type of procedure would include a creatinine of greater than 1.8 to 2, colitis or other intestinal disease such as carcinoma of the colon and rectum, as well as a variety of other comorbid conditions, both physical and mental. As we stated earlier in this presentation, a continent urinary reservoir would be categorized as a catheterizable stoma. The cock pouch is not done any longer. However, you may encounter a few individuals who have had this type of procedure done in the past. The cock pouch was replaced by the Indiana pouch, which is surgically easier to create. In the Mitrofanoff procedure, also called an appendovasicostomy, the appendix is sutured to the bladder and is used as a catheterizable channel. The proximal end of the appendix is tunneled into the bladder, and the distal end of the appendix is brought through the skin and serves as the entryway into the bladder. This procedure is usually done for children with spinal complications. The orthotopic neobladder, also called the Studer pouch, is another type of continent diversion that allows the person to void through the urethra. Anyone who has had any of these diversions should have some type of medical identification in case they're not able to speak for themselves and require urgent medical care. The Indiana pouch is composed of the rectum, ascending colon, and about 10 centimeters of ileum. Continence occurs as a result of plication of the ileal segment used, detubularization of the colonic portion, and the presence of an ileocecal valve. The ureters are tunneled along the posterior colonic tenia in order to provide an anti-reflux mechanism to this internal reservoir. The individual empties this type of internal reservoir by catheterizing the stoma located on the abdomen, usually within the umbilicus. Sometimes the abdominal stoma can be found in the right lower quadrant. The Studer pouch is composed of ileum and continence and relies on the strength of the individual's external sphincter muscle. An anti-reflux is created through the surgical technique, and the internal reservoir or pouch is emptied when the individual relaxes his or her external sphincter muscles and bears down with the abdominal muscles. Male patients may find the need to void while sitting down. Catheterization and irrigation may also be required. The continent urinary diversion now done is the ileocecal reservoir or Indiana pouch. In the past, the style of continent urinary diversion was the Koch urinary pouch. However, this is no longer done due to a high and unacceptable complication rate as well as difficulty with the surgical creation of the pouch. However, you still may encounter some patients who have had this Koch style reservoir surgically created. The ileocecal reservoir is generally referred to as Indiana pouch. In the procedure, a right hemicolectomy with the ileal segment attached is done. This involves removing the right colon from the segment to the mid-transverse colon. An appendectomy is performed while preserving the ileocecal valve, and this is used to create an internal pouch. To create the pouch, the intestine is opened on its anti-mesenteric border and folded over to create a reservoir as seen in photo B on the slide. The ureters are then tunneled or implanted into the reservoir in such a way as to provide an anti-reflux mechanism to prevent backflow of urine to the kidneys. There will be one stent per kidney. Now, generally, a small stoma is brought out on the abdomen together through a stab wound on the anterior abdomen. A catheter is inserted into the ileum, and the ileum is plicated around the catheter. The end of the ileum is brought through the abdominal wall as a stoma. Usually it is brought through the umbilicus, and one can barely, if at all, see the stoma within the umbilical depths. Continence is provided through three mechanisms: the low-pressure reservoir, plication of the small intestine around the catheter, and the ileocecal valve. There is one stent per kidney. So, looking at the picture above, how many kidneys does this individual have? Nursing considerations for care include irrigation of the cecostomy and stomal catheters with sterile, normal saline per physician's order to maintain patency of the entire system. It is permissible to draw back a bit when irrigating these catheters in order to help facilitating removal of mucus. Remember, the pouch is constructed from large intestine, which will contribute mucus in the urine. One needs to encourage fluid intake as well as appropriate irrigation in order to maintain tube patency and diminish the risk of a urinary tract infection. It is also extremely important to stabilize the tubes to prevent accidental dislodgement, as well as pulling on the patient's abdomen, which would cause discomfort. There are also drains, generally 2 Jackson-Pratt drains, that will exit the abdomen. There is an indwelling catheter in the urethra that serves as a pelvic drain, and one should never irrigate this catheter. The patient will go home with a cecostomy and stomal catheter if one was placed. The individual needs to know how to irrigate and stabilize the catheters, pouch the stents, which are usually left in place for 3 to 4 weeks, and change the dressings. Care of the bedside drainage bag or leg bag needs to be done as well. When the patient returns for follow-up, a pouchogram or X-ray of the internal pouch is completed to evaluate the healing process. If there's no extravasation or leakage of the contrast material, the patient then can be taught how to intubate the stoma. The usual intubation schedule will be about every 4 hours. When creating a Studer pouch, the surgeon uses the small intestine or ileum, creates the reservoir, implants or tunnels the ureters into that reservoir, and connects the internal reservoir to the urethra. This internal reservoir is dependent upon the external urinary sphincters for continence. Although it can be done in women, it is most generally done for men. Success rates are actually not as good in women. Postoperatively, there are the same types of tubes as in patients with an Indiana pouch, minus the stomal catheter. Those with a Studer pouch will have an indwelling catheter into this neobladder to drain the urine. Patient will need to learn how to irrigate the tubes, methods for stabilizing the tubes, as well as dressing changes. Once healing has occurred and the pouchogram reveals no extravasation that indicates a leak, the catheter can be removed and the patient will need to learn to empty the bladder through the urethra. However, the mechanism of action is slightly different. Emptying of the neobladder includes relaxing the external urinary sphincters while bearing down using the abdominal muscles. Kegel exercises need to be done to strengthen the external sphincter muscle, as this is the only continence mechanism. Male patients may find a need to void while sitting down. In all patients, self-catheterization needs to be taught, as well as irrigation, in the event of clearing mucus, and also in the event voiding does not occur. Listed on this slide are complications that can occur with any continent urinary reservoir. The photo is of a calculi that was retrieved from an internal pouch. The minerals precipitated onto the suture material and served as a locus for urinary tract infection. Studies indicate that 15 to 30% of patients will experience some type of complication following neobladder formation, and the rates may be higher for the catheterizable stomas. Stents are used with both continent and conventional urinary diversions. Stents, one for each kidney, are normal and serve as a splint for the uretero-ileal junction, as well as a pathway for urine to exit the kidney in case edema would occlude that uretero-ileal anastomosis. The stents will remain in place for about 4 weeks and are easily removed at that time. Each stent's protruding end is cut differently. The stent that is in the right kidney is cut straight across, also called a right angle, and the stent in the left kidney is cut at an oblique angle. When removed, they come out one at a time in order to determine which side is affected with a problem with regards to urinary function after stent removal occurs. For example, if the right stent is removed and a significant decrease in urinary output is noted over the next 2 hours, one could surmise that there is difficulty with the right side. All patients with any type of urinary diversion need to be taught signs and symptoms of urinary tract infection. The symptoms that the individual would have been familiar with when a bladder was in place can no longer be relied upon for symptoms of urinary tract infection. A change in the odor or color of the urine, increase in mucus shreds, flank pain, and fever are all signs that can indicate a urinary tract infection. Adequate fluid intake, use of constant drainage at nighttime for those with conventional stoma, and maintaining the urine at a slightly acidic pH are measures used to help prevent a UTI. Individuals may also find vitamin C or cranberry tablets helpful in maintaining an acidic pH. It's important to note as well that an individual who's on warfarin or Coumadin should avoid cranberry products. This concludes our lesson on construction of continent urinary diversions. For more information, please refer to Chapter 6 of the WOCN Core Curriculum for Ostomy Management. Thank you for your attention.